Okay, perfect.
Okay, so we're ready to start our topics in fetal medicine. We're privileged to have Jennifer Webb from the Division of Hematology and Transfusion Medicine come, and she's going to be talking about fetal hematologic conditions and implications for pregnancy and delivery. And there will be time for questions at the conclusion of the presentation. Thank you.
Wonderful. So first, thank you all for having me. I'm kind of relatively new faculty here, and my position is a little bit unique because I am split between the divisions of hematology as well as transfusion medicine. And so for these cases, I've seen kind of both sides, not only kind of when the hematologist gets the call after the fact once the baby's in the NICU, but also that prenatal call. We need to do an in utero transfusion. How do we manage that? And that's kind of the call that I get wearing my blood banking hat. So I've been able to see both sides to some of these. And again, the title, Fetal Hematologic Conditions, Implications for Pregnancy and Delivery. And my objectives for this are to develop a differential diagnosis for prenatal and neonatal thrombocytopenia. I want to describe pathological mechanisms for NATE testing and therapeutic implications, and we'll spend a lot of time on that. I was asked to speak a little bit about TAR, the thrombocytopenia absent radius syndrome. So I'll briefly talk about that and what testing is available for that here. And then review perinatal management of mothers of fetuses with a family history of hemophilia, kind of what do the guidelines say regarding how to manage these infants. So when I get a call about thrombocytopenia in the NICU, I tend to think of, well, what is the timing of this? Is this something that occurred during fetal life? And when I think of things that cause fetal thrombocytopenia, I think of, NATE, fetal neonatal alamine thrombocytopenia, NATE, depending on how you pronounce it. Congenital infections, trisomies, maternal ITP, though oftentimes the maternal platelet count will also be affected. I think about ABO, HDFN, the hemolytic disease of the newborn, because your platelets carry A and B antigens on them. And then Wiskott-Aldrich. Early in the NICU course, I think about insults to the infant. So fetal hypoxia, IUGR, perinatal asphyxia, perinatal infection, group B strep, E. coli. I think about sepsis and DIC and consumptive coagulopathies. NATE, maternal ITP, congenital infections, thrombosis as also a mechanism of platelet consumption. Congenital leukemia, though rare, it can cause, if there's a massive marrow infiltrate, can cause thrombocytopenia. Kasabach-Merritt phenomenons, again, you have a giant malformation, vascular malformation that causes a consumption. Metabolic disorders, and then other congenital thrombocytopenias like TAR, congenital megakaryocytic thrombocytopenia, or CAMP. And then later on in life, greater than 72 hours out, late onset sepsis, NEC, still some of those other things, congenital infections, Kasabach-Merritt, metabolic disorders, and then congenital thrombocytopenias. And then when I think about congenital thrombocytopenias, I kind of break them down into, are they macrothrombocytopenias? They have large platelets. And that's kind of that second group there. I think about the Bernard-Souliers. I think about the MYH9-related diseases. I think about the type 2B von Willebrand's disorders. Are they microthrombocytopenias? And those are very classically the Wiskott-Aldrich, the little boys. And then the kind of normothrombocytopenias, congenital disorders like CAMP and thrombocytopenia absent radii syndrome, the RUNX1 mutations. But many of those, they may present in the neonatal period. Some of them don't present until later in life, again, because the thrombocytopenia may be variable. And if you don't have cause to get a CBC in that, newborn nursery, you may or may not pick this up, and they'll come to hematology, after their, 9-month or 1-year CBC when they're identified as having platelet counts of, 80. So I wanted to present just a quick case to kind of tie things, ground them in reality. So an infant born at 39.5/7 to a 28-year-old G1 pair 0, no complications. Infant noted to have significant caput and petechiae at the sites of the BP cuff. Infant is slow to latch and feed, and then the head ultrasound reveals intracranial hemorrhage, and the CBC reveals isolated thrombocytopenia with a platelet count of 7. And kind of the isolated platelet count of 7, you guys will see as a bit of a theme. And so for me, kind of the intracranial hemorrhage very early on in life, this other signs of bleeding, this CBC that shows the isolated thrombocytopenia, this is kind of NATE, neonatal alloimmune thrombocytopenia, or fetal neonatal alloimmune thrombocytopenia. It occurs in 1 in 1,000 to 1 in 5,000-ish live births. It has a fairly significant mortality rate, and much of that mortality is related to intracranial hemorrhage, which occurs in about 20% of these kids. And of those, 20 to 50% occur in utero. And this is probably where those beautiful MRIs that you guys were showing can pick that up. You can see that bleed. And you can kind of see why. So is this going to let me do this point here? Okay. So this is gestational age, and you can see that in fetuses who are affected with alloimmune thrombocytopenia, their thrombocytopenia can be very impressive very early on in gestational age. These are platelet counts less than 20 back in the 20th week. And so you can see why they may or may not be prone to bleed. Comparing this to unaffected term neonates, where symptomatic intracranial hemorrhage rates are 2.7 to 4.9 in 10,000 live births. And if you look at asymptomatic, if you do MRIs on kind of all babies that are born vaginally, that gets a little bit higher, well, a lot higher. But again, it's still not the incidence that you're seeing with NATE. The presentation is often significant thrombocytopenia, prenatally or neonatally, prenatal intracranial hemorrhage. And what's key to this is, again, the maternal platelets are normal. If this was a maternal nonspecific ITP-type antibody that's crossing the placenta, then her platelets may or may not be affected too. Every now and then you'll get fooled if mom has a history of chronic ITP and she's had a splenectomy, then the infant may be more disproportionately affected than the mother. And the etiology, when you can pin it down, it's a maternal IgG antibody directed against paternal platelet antigens. And those may or may not enter fetal circulation sometime between 10 and 12 weeks gestation. They bind to the fetal platelets, causing them to be removed by the fetal reticular endothelial system. And if you are going to find an antiplatelet antibody in the Caucasian population, the majority are going to be HPA1. I can keep rocking and rolling. Illegal? Should I keep going? Or should I wait?
How about any questions?
We often have some of those concerns about the NICS. So I know that you'll probably discuss it in your process right here, but do you see a lot of benefit from the treatment of the subsequent pregnancies with steroids and IVIG?
Oh, we are going to go into that data.
Yeah.
Oh, looks like.
Yeah, he said call ended by Ron Dixon.
Huh?
The call ended by Ron Dixon.
I don't know.
And just as curiosity,
Oh, good.
who do you have to do in utero transfusion blood preparation for? Because I haven't done one over at hospital centers for 9 years, so I'm interested to know whose blood you're taking care of.
There you go. So where I did my training, we did in utero transfusion, so that was up in Philadelphia.
Okay.
Here we do have a new protocol, so where if there was a push to do blood transfusions in utero transfusion, it is something that we are working on having available to our MSM colleagues.
So you would have the blood available here that we could use for our systems, or would we have to do it here?
Have to do it here. But I don't know who runs the blood bank over at Washington Hospital Center.
I can tell you.
Yeah. The blood for in utero transfusions is very specific, and it takes a lot of coordination to get done.
Yeah.
But it certainly can be, depending on your blood bank. But we'll talk a little bit more about that. And we'll go into the ideas about treatment and the utility of in utero transfusions, actually. Again, HPA1 in your Caucasian population, that's your most likely to be discordant platelet antigen, formerly known as PLA1. It has a couple of other names. It's more likely than HPA, but than the HPA other ones, and we'll talk about all the rest of them. But in Asian populations, there is almost no discordance between HPA1 antigens, but you get more discordance between your HPA5B. And so in kind of the heterogeneous population of DC, the ethnicity of the family really plays a role in deciding which you think is the most likely to be causative antigen. There are also HLA antibodies that can cause this. If mom has had multiple previous pregnancies, she can become sensitized, and HLA antibodies are carried on platelets, as well as anti-A antibodies. If it's a high enough titer in the mom, you can see those destroying the platelets as well as an autoimmune phenomenon.
And do you still only have the Clinic for Blood Research in Wisconsin as the only reliable place that you can do this test?
Yes. Yes. So these are various HPAs, and there are more, but this is kind of the main ones. So HPA 1 through 5, 6, 9, and 15. And these are the antigenic frequencies. So in Caucasians, you can see that about 98% of people have HPA1 either homozygous or hemizygous on their platelet. But now, I told you that the frequency of NATE is 1 in 1,000 to 1 in 5,000.
When you
it's
say
not.
hemizygous, does that imply that this is X-linked?
Oh, no, I just mean that in terms of they might be heterozygous with the HPA1A, 1B. Sorry. So why don't we see 2% of pregnancies having this discrepancy? And that's because of another association between HPA1A alloimmunization and HLA-DRB3-0101. If mom carries that HLA type, it's thought, because of the way DRB3 presents the HPA1 antigen to the rest of the immune system, it is thought to be more antigenic. It presents more antigenic epitopes. And so it's because of this kind of then-again association that we don't see it in 2% of our patients. We do know that you have increasing severity with successive pregnancies, and we know that increasing titer of these HPA1A antibodies correlates with increasing thrombocytopenia, but it is something that is very hard to standardize. And we'll talk a little bit in a minute about this testing. But you can see in this study where they kind of set an arbitrary cutoff, they literally made it 250 arbitrary units because of the way that they were doing this testing. And you can see that in all weeks of gestation, if the fetal platelet count was less than 50, you were much more likely to have the mother was much more likely to have a high titer arbitrary unit versus if your fetal platelet count was greater than 50, the mother tended to have this lower arbitrary unit. And you can see it's got pretty good sensitivity and fairly good specificity. It is more apparent kind of in those fetuses that had thrombocytopenia early in gestation, but it remains true kind of later in gestation as well. 92% of cases with the sibling history of fetal intracranial hemorrhage had severe thrombocytopenia at 24 weeks, and we'll talk about what that then plays into the risk of intracranial hemorrhage in that subsequent pregnancy. And then 66% of cases with a sibling platelet count less than 20 also had severe thrombocytopenia at a median age of 28.5 weeks. So again, you know, if that first pregnancy was affected, that subsequent pregnancy is more likely to be affected and potentially more severe. And unfortunately right now, the only predictor of intracranial hemorrhage is intracranial hemorrhage in a previously affected sibling. So these are 19 siblings of kids of 19 subsequent pregnancies whose older sibling had an intracranial hemorrhage, or at least was suspected of having intracranial hemorrhage. And the majority...
And NATE.
And NATE, yes, exactly. So they either had an unexplained thrombocytopenia in a fetal loss with a large bleed, or they were actually born with kind of suspected NATE. And 72% of these subsequent siblings ended up having intracranial hemorrhage, but 21% did not. So they did some kind of rough math and said, well, if you had a sibling who had NATE but did not have an intracranial hemorrhage, your chance of intracranial hemorrhage is only about 7%, 10% round about there. So that's kind of tough math. And actually,
how did they diagnose those? If they didn't have a bleed, how did they know to test for thrombocytopenia?
So all their siblings had had intracranial hemorrhage or suspected intracranial hemorrhage. And so these are the subsequent pregnancies.
Got it.
Yeah. But there was a recent study looking at subsequent pregnancies in a population of Norwegian families that had been screened for having HPA1A incompatible fetuses, infants. And none of the mothers received IVIG because these were kind of low-risk families. They were just picked up on screening for having HPA1A incompatibility. And in those index neonates, 38% had normal platelet counts. In the subsequent pregnancies, 29% were unaffected as well.
how did they determine the incompatibility? They tested mom and
They tested mom and dad.
and father.
Yeah. Usually they screen for HPA 1B, 1B homozygous moms, and then they'll go and test dad. In the subsequent pregnancies, what was really interesting to me is that platelet counts were improved in 18% of the cases, unchanged in 52%, but worse than 30%. There was one case of intracranial hemorrhage in the index cases, but none in the subsequent pregnancies, which is kind of interesting. But again, this is selecting for a very benign population, whereas in the study previously, they'd been selecting for those kids with a sibling with intracranial hemorrhage.
Did they deliver the second babies differently in these cases?
I don't believe so. I don't believe they did, but we'll talk about mode of delivery in a little bit. And we'll actually talk about it most with hemophilia, the family history of hemophilia. Maternal HPA-1A antibody titer was higher in those pregnancies, that 30% that had lower platelet counts. So again, that kind of correlation with titer, but again, titers are hard to standardize. So speaking of testing, there are indirect methods of testing that we can do to assess your HPA antigen or any discordances between mom and dad. So there's genetic HPA antigen determination. We can send, DNA samples from mom and dad. There are ELISA tests where you have platelet antigen attached to a solid well, and then you have a platelet-specific, it's attached with a platelet-specific antibody, and then you see where the maternal serum binds. And then because the secondary anti-IgG with a catalyst activates some sort of indicator, usually it's colorimetric, that you can then see, and it will tell you which antigen mom is binding to. There are flow techniques, and those are used by Blood Centers of Wisconsin. And there's something called the monoclonal antibody-specific immobilization of platelet antigens, or the MAPA test. And this is something that was used when they established those arbitrary units. This is what they were using. And I'll show pictures in a second. I'm a very visual person, so I need to see the sandwiches of the antibodies. In these, platelets and serum are incubated and then lysed. And then a mouse anti-platelet monoclonal antibody is incubated with the platelet fragments. And then a goat, anti-mouse, IgG, fixes the reaction to the well. So you can see why a picture is worth a million words in this case. So on the left, you have the ELISA test. And so you have the platelet antigen here being bound to the well. You wash mother serum into this well, incubate it, allow it to bind, and then you have a secondary anti-IgG that activates some sort of indicator. MAPA is very similar to that, except you can have you don't necessarily have to know what the antigen on the platelets is. You can just incubate maternal serum with paternal platelets. You lyse it all, and then you will be able to bind it in there, and you can do basically a cross-match for these platelet antigens and look for any discordances. You can do a direct platelet cross-match. There's something called the solid-phase red cell adherence method, the SPRCA, where maternal serum is again tested with paternal platelets. The platelets are coating on, you have to set up the test that you have the platelets coated on microtiter wells, and then you use red blood cells with an anti-IgG as your indicator, which will then kind of coat nicely along the plate if it's positive. And then there's something called the platelet suspension immunofluorescence test, the PSIFT, which is a fairly subjective test, but it's a direct visualization of antibody on intact platelets. And if it's positive, if the cross-match is positive, that there's an incompatibility, there's a fluorescent ring that will be around a platelet. If it is not, then you'll see like a ghost outline. There won't be any fluorescent ring.
So
but
this
again,
is like the rosetting for red cells?
It's a little bit different because you're actually looking at a fluorescently tagged antibody along the outside of platelets. And so you are looking at it under the microscope, and in that sense, it's kind of similar. It's very subjective, kind of like rosetting. Well, rosetting is less so, but kind of like the Kaijar-Becky test. And yeah, so you're kind of looking for ghosts, non-ghosts. I can see, yeah, yeah. So what is prenatal treatment? So in the 90s, they started trialing IVIG because, again, there were thoughts that, we know that it can downregulate some immune phenomenon. We know that it can cross the placenta, plus or minus steroids, downregulate the maternal antibody response. And so in 1996, 54 women thrombocytopenic fetuses were randomized to receive IVIG with or without dexamethasone. And these were thrombocytopenic fetuses. They'd done pubs. They'd established their thrombocytopenic nature. And in these, the vast majority responded by increasing platelet counts up to, by 30 to 69,000 per microliter. There was no difference with the addition of dexamethasone. And nowadays, I think that we tend to discourage dexamethasone in the prenatal period. It does cross the fetal blood-brain barrier, may cause oligo, has some detrimental effects. But what was really interesting is they were able to salvage half of the IVIG non-responders. So these are platelet counts that did not respond on subsequent, pubs, with 60 mg per day of prednisone. And in these pregnancies, there was no intracranial hemorrhage. And I can't recall exactly how they picked up those thrombocytopenic fetuses. I think it may have been a previously affected sibling.
It was all previously.
That being said, so IVIG steroids, it's a panacea. We've fixed NATE, but unfortunately, subsequent studies have shown that 1 mg per kg per week is sufficient for fetuses with an already pretty good platelet count of greater than 20, but it might be less efficient with platelet counts less than 20 or in a sibling with a history of intracranial hemorrhage. So in those more severely affected siblings, IVIG plus or minus steroids may not be enough. Cochrane Review kind of put all the data together in 2011, 4 studies, 206 patients, mostly comparing prednisone versus IVIG, found no differences in outcomes, IVIG plus steroid versus IVIG alone, no difference, and concluded that optimal management really remains unclear because, hopefully what you guys have gathered from this is that there seems to be kind of a spectrum of NATE. There's kind of the ones with the maternal antibodies with maybe an unaffected fetus. They're the ones with an affected fetus but moderate thrombocytopenia. They're the ones with the severe thrombocytopenia without intracranial hemorrhage, and then there's kind of the intracranial hemorrhage and siblings with intracranial hemorrhage. So there's kind of a spectrum. In a recent study, they managed pregnancies with IVIG 1 gram per kilo per week from 20 weeks and steroids during the last trimester, and they reserved these for very high-risk pregnancies. And what they were trying to do is they were trying to find an alternative method versus kind of direct fetal platelet count determination, which, comes at a price. There's a risk of fetal loss, there's a risk of fetal hemorrhage. Whether or not there was a way in mom to monitor that antibody titer to see if maternal response would then be reflected in fetal response. And so they did sequential HPA-1A measurements using the MAPA in 55 pregnancies and calculated an area under the curve based on the maternal antibody and the time between the first and last titering based on the MAPA. And what they found was that an area under the curve of less than 23 international units per ml was associated with safe newborn platelet counts. So platelet counts greater than 50, which is, very hemostatic in the newborn period, with, sensitivity of 76% and specificity of 78%. And so at the conclusion of their paper, they recommended a vaginal delivery if the AUC is less than 23 and a C-section when the AUC is greater than 23, greater than or equal to, or if there were other high-risk features, again, a sibling who may or may not have been affected. But unfortunately, that's kind of a very hard test to get because getting those MAPA titers is a real challenge, and I'm not even sure how feasible it is outside of a research setting. Again, speaking to kind of the variability within NATE, there was a recent study looking at low-dose versus high-dose IVIG in an effort to kind of spare mom some of the toxicities potentially related to IVIG, randomizing mothers to either 0.5 mg per kg per week or the regular standard 1 mg per kg per week. And again, these were subsequent pregnancies, but none of the previous siblings had been affected by intracranial hemorrhage. So again, kind of selecting a little bit of a lower, not lower risk, but a safer population. It unfortunately was closed early due to poor accrual. They had no intracranial hemorrhage, and there was really no difference in the platelet counts between the two groups. But because it closed early to low accrual, they weren't able to say statistically this is a non-inferior option. So what about prenatal transfusion? There is the availability of in utero platelet transfusion. It does require specialty maternal fetal medicine care and a lot of coordination with transfusion medicine and the blood bank. These are very specific products that we are going to be requesting for you, and so as much information as the blood bank has to be able to do that is kind of the best. Oftentimes we will like to know mom and dad's full HPA genotype before we select a product. And the reason why is because if this is a family that wants to go on to have subsequent pregnancies, we don't want to potentially sensitize her to another one of the HPA antigens with this transfusion. And there is a not insignificant risk of fetal loss, so that always has to be weighed when you're considering in utero transfusion. And each center kind of has its own rates of loss and bad outcomes, and so it varies a bit. There are a lot of questions that remain about therapy for NATE. You know, when to initiate maternal therapy. Some people would say 2 to 4 weeks before the previously affected sibling was identified. Some people would say 2 to 4 weeks before kind of that 20-week mark, because we know that this can start early. Certainly, you may or may not want to initiate therapy before any sort of PUBs or any sort of intervention, so it may cloud your diagnostic picture. Low dose versus high dose IVIG. Well, does that depend on the risk status of the fetus, and if so, you know, what exactly are kind of those markers of being a high-risk fetus? And then how to determine efficacy of these therapies. Is it going to be serial in utero platelet measurements, or is it going to be this AUC and the maternal antibody titers? And then steroids or no steroids is always kind of a fun one. So this was a algorithm that was developed as kind of, you know, a theoretical one that could be tried in patients who are very high risk, either with a previously affected sibling or previously affected sibling with intracranial hemorrhage. And this uses PUBs and direct fetal platelet count measurements. Again, kind of first you want to determine paternal zygosity and or the fetal genotype, kind of, you know, you have this previously affected sibling or you have this potentially affected fetus, determine the maternal and paternal genotype, and then perform a PUB 20 to 24 weeks for fetal antigen phenotyping and fetal platelet count. If the platelet count's greater than 100 at that time, repeat the PUBs in 4 weeks to reassess the platelet count. If there's no thrombocytopenia, repeat it 36 weeks, and if there's no thrombocytopenia still, take it to term. If the platelet count is less than 100, then you can initiate IVIG and steroids. And some people might argue that given the risk of PUBs intrinsically, that may be started back here before you even perform your first PUBs. But again, that may cloud your picture a little bit. And then repeat the PUBs at clinically determined intervals. If it's a very thrombocytopenic infant, you're going to want to repeat them more frequently. And then PUBs at 38 weeks to determine method of delivery. And with each of these direct assessments of fetal platelet counts, you want to have antigen-negative platelets available immediately. These are also sickle cell negative because there are a few red blood cells in your platelets. These are also CMV negative. And actually, many of our antigen-negative platelets come from mothers who've previously had an infant with NATE. There's kind of a whole stable of donors out there of moms who know that they're HPA-1b homozygous who are willing to donate kind of at the drop of a hat for us, which is amazing. How to calculate the platelet transfusion volume? It's based on the fetal placental blood volume, which is determined by gestational age. You have your goal platelet count, usually about 100, minus the actual platelet count, the donor platelet concentration, which the blood bank will give you, then you multiply it by the fetal blood volume. Once the baby is born, we have several options as to how to transfuse this child. We can collect and infuse washed or concentrated maternal platelets. So if mom is unaffected, she has a robust platelet count post-delivery, we can actually freeze her down in the donor center here and have those platelets available for you later in the day. You do want to concentrate them because her plasma, which is what the platelet counts kind of exist, what the platelets exist in, they do have that antibody in that plasma. But her platelets we know are antigen negative, so they're probably one of the safest things we can give. You can also, again, the other nice thing about that is because that product, those platelets from mom will be untested, families tend to be a little bit more open to saying, yes, go ahead and give an untested product, we'll kind of sign our life away because that baby has just been living in mom. You know, they've kind of shared it all up until that point. And so you kind of think about that as being less of a risk. Again, if we know when delivery is going to be, we can have antigen-negative tested platelets available. You can give unmatched platelets with IVIG and steroids, and usually the infant will recover its platelet count in 10 days to 6 weeks after birth. And so this is kind of the algorithm that I go through when I'm seeing a neonatal thrombocytopenic baby that's suggestive of NATE. Again, I'm kind of sending off that workup to Blood Centers of Wisconsin. And then I'm figuring out, is there significant bleeding? Is there intracranial hemorrhage? If yes, I'm just going to transfuse this baby whatever platelets I've got. I'll give IVIG and steroids, and if I can get mom to donate, I will. If mom's not a good candidate, I'll be calling the Red Cross to get HPA-1A negative platelets if they're Caucasian in-house as soon as possible. But knowing that it'll take time, I'll just give them whatever we have. If there's no intracranial hemorrhage, but the platelet count is significantly low, I'd go ahead and transfuse them, or I might just start with some IVIG and some steroids for the infant just to see if we can get them to kind of boost on their own. If it's greater than 30, I just watch them. So we've talked about there's this spectrum, but what if we could screen for this? Because we do have these therapies that may or may not be moderately helpful, especially if we're picking up these infants before they have kind of those high-risk features. So one of the screening studies looked at screening of low-risk infants for thrombocytopenia with just a CBC. Just every baby who comes to the newborn nursery gets a CBC. And they found severe thrombocytopenia, so platelet count less than 50, in only about, 0.15% of infants. Of those, about a third, it was because of NATE. They kind of finally identified that this was due to an antiplatelet antibody. And in about a quarter of those, they had intracranial hemorrhage. And because, again, there was such a high proportion of infants that had intracranial hemorrhage, at the conclusion of this, they recommended screening for HPA antibodies among all pregnant females, not even waiting to get to the thrombocytopenia in the newborn. That was too late. We'd already missed the boat there. In a pilot screening of molecular screening of 26,000 mothers in Scotland, they found that about 2%, which is exactly what we would expect in the Caucasian population, were HPA-1b homozygous, but only 9% developed antibodies. So again, using a molecular screening as opposed to an antibody screening, we're picking up a lot more mothers. We're picking up all those mothers with that phenotype, but not all the ones who may have that associated DRB3 that makes them more predisposed to have antibodies. And currently there's a prenatal molecular screening for mothers in Norway looking for, again, the HPA-1b homozygous and treating them with an anti-HPA-1A antibody, so kind of like the platelet ROGAM equivalent, but that's not available here, something that's kind of new and cool.
And when would they dose it?
When are they dosing it? They're dosing it very early, I want to say, like remarkably early, like back in the 16, I think before 20 weeks. But I don't know how many times they're actually continuing to dose it throughout the pregnancy. How long do I have?
Really not much longer. So maybe just quick, but can you just quickly, because both of these are very important.
I'm going to buzz through really quick. So thrombocytopenia, absent radii syndrome, kind of the classic finding in this that you guys will see on your prenatal ultrasound is the usually absent radius, bilaterally, lower limbs are unaffected, sometimes you'll have a shortened humerus, and the presence of thumbs. In Fanconi's anemia, you can also have absent radii, but they typically, if they have an absent radii, also have an absent thumb. So that's kind of how we distinguish those. And let me just, it's a very interesting autosomal recessive disease that's typically due to compound mutations in the RBM8A gene. It's an RNA-binding protein involved in a variety of cellular functions. Usually you get one kind of large microdeletion, chromosome 1q21.1, and then that gets combined with a hypomorphic allele, either due to single nucleotide polymorphism in the 5' untranslated region or in the first intron. And what you get is kind of very, very diminished expression of this Y14 in a cell type and developmental stage specific manner, which is why it has such a variety of characteristic manifestations. And this is a look at the case reports of TAR being identified on prenatal ultrasound, and 19 cases, so again, it's very, very rare. And in 19 out of 19, kind of upper limb abnormalities, radial hypoplasia or aplasia being kind of the most frequent ones. This is what you guys will be picking up. And what was very fascinating about this disease is I found that there's established testing through Emory or Cincinnati Children's, but at CNMC, if we have enough heads up, we can also get this done here. Looking the prenatally on the fetus, if you can send us a fetal sample.
So you do a lab, you have a molecular lab here?
We have a great molecular lab here. We can do basically any genetic testing, but not on prenatal.
Oh, no, not at all?
They're not certified yet for prenatal.
Oh, I asked Sean, and he said that if we knew what we were looking for, we could go for it. It may just have to be in the postnatal life.
It's super for each.
Yeah,
I mean, they can do the test, they just do it on
different sample.
non-prenatal.
And have we sorted out billing?
That's the problem with prenatal.
Yeah.
Oh, it's a billing phenomenon.
It's the billing and it's a different sample handling kind of approval.
Yes.
All right. The nice thing about them is typically they get better. They tend to bleed in the neonatal period with platelet counts less than 10, so transfuse them greater than 10. And then typically it resolves around 2 years of age. The thrombocytopenia is variable. But it may progress, unfortunately, to MDS, ALL, or AML in adolescence. But again, typically in later adulthood, their problems are more orthopedic in nature.
But so they don't really bleed in utero?
Typically not. Well, but it's so rare. Again, it's kind of hard to know, but typically no.
Good recommendation for delivery?
No, not that I know of. Again, I think that with any vaginal delivery, it's going to be a higher risk for bleeding than a cesarean, especially an unlabored cesarean section. And so then kind of when
as an obstetrician, I always struggle with that because there are times when it is really hard to get out the fetal head. And the head, by my manipulations, is equally manipulated as if it comes through the vagina.
By C-section, you're saying it's hard to get the head out.
Yeah. Just because you make a cut doesn't mean it's easier. Sometimes, especially in a premature infant.
Okay, and the last case we have hemophilia.
Yeah, so the last case is a known family history of kind of free bleeding, and I kind of skipped past it. This was a large study looking at babies born in California, looking at the risk of intracranial hemorrhage, live-born singleton infants. With forceps and vacuum, the risks of intracranial hemorrhage, and these are mixtures of all babies, all comers. But typically, because of the rarity of bleeding disorders, there's the majority of these are unaffected infants. And you have a higher risk of bleeding with forceps and vacuum, cesarean section during labor.
I'm sorry, these are for hemophiliacs?
No. These are normal singleton infants. But a cesarean without labor, again, your risk of intracranial hemorrhage is much, much lower, even with that manipulation, potentially. And so because of that, we have specific guidelines for those patients who would be at very high risk. And for the sake of time, I'll run through kind of how we counsel at the time of delivery when we as the hematologist get the call, this mom has this history, nobody picked it up before now. I did want to give a special plug, though, that if you are seeing a mother who gives a history of free bleeding, which is what I'm told people colloquially call it here, then the Hemophilia Center does do prenatal assessments and evaluations, and we can do a full pedigree, we can do maternal carrier testing, and that can all be arranged ahead of time, give you guys a specific delivery plan and kind of weigh the options with the families. Again, kind of weighing the risks to the mother and weighing the risks to the fetus for the various modes of delivery. What's really critical is knowing the gender of the fetus. Even if the family doesn't want to know, the hematologist desperately wants to know the gender of the fetus. Again, because hemophilia A and hemophilia B, factor 8 and factor 9 deficiencies are X-linked. Hemophilia C, factor 11 deficiency is autosomal recessive and a little bit more variable and much less common, thankfully. So if this is, a family with a history of hemophilia and it's a female fetus, no special precautions or management. So typically we would recommend referring her at some point to a hemophilia treatment center just so that she could be assessed for her carrier status, because that will have implications for her as she grows up. If it's a male fetus with uncomplicated labor, you can consider a vaginal delivery, just knowing that you do not want to do any instrumentation. You don't want to use forceps, you don't want to use vacuum, so this has to be kind of a very smooth delivery. If there's any sort of complicated labor, consider early C-section, and again, avoiding excessive manipulation if you can in the C-section. In both of these cases, you want to avoid fetal scalp monitors. You can send the cord blood for everything that we need to diagnose hemophilia in a neonate. You can send it for a PTT, and if you know whether it's 8 or 9, you can send it for both, or you can send it for one. And really what this does is it avoids kind of the venipuncture later in life, but you can venipuncture the kids. You absolutely want to avoid arterial sticks in patients with suspected hemophilia. If the PTT is prolonged beyond the normal range, and again, all neonatal PTTs look prolonged. It'll highlight in whatever, operating system you're using, because they are typically prolonged. But if it's beyond the newborn range adjusted for gestation, you pretty much assume hemophilia. Get a head ultrasound before that child leaves the newborn nursery. Delay circumcision. You want to avoid IM injections and ART sticks. You can give your vitamin K either orally or sub-Q, and you can give your hepatitis B vaccine sub-Q. And if you are going to do a venipuncture, say that cord just clamps right off, you can do venous or heel sticks, but you have to monitor those sites very closely for bleeding and apply, several minutes of good pressure after the fact. And then again, refer to a hemophilia treatment center. So I tried to kind of condense all this down to one very specific page, so if you take nothing else away from how to manage hemophilia in the DR, this is kind of what we as hematologists would recommend. And then the conversation to have an unlabored scheduled C-section versus a vaginal delivery, that's a long conversation to have with mothers. Especially if they are carriers of hemophilia B or factor IX deficiency, that doesn't go up as much during pregnancy, kind of very different from factor VIII. And so they may themselves be, the moms, may be more prone to hemostatic challenges with a cesarean section, and so it may be a benefit for those moms to have a vaginal delivery. And again, C-section, it's a big operation, so, it's nothing to be taken lightly in people who have moderate, mild factor deficiencies.
Well, thank you so much. If there's anyone online who has any questions, they can unmute their phones now and ask them. Any outside questions? Okay, I did have one question for hemophilia. We had a recent case where at 3 or 4 days of age, they developed the bleed. So do you recommend getting a follow-up health ultrasound a few days after delivery as well?
So the unfortunate circumstance, if I believe that this is the correct case, is this kid left the neonatal nursery without getting that initial head ultrasound.
So they probably should be positive typically.
Exactly. And the problem with hemophilia is they can form a very unstable clot initially, but then they tend to kind of ooze. And so that's how you get into trouble with the joint bleeds, is they have some kind of initial injury, and then they kind of form a little bit of clot, but then it kind of just persistently oozes. It's not a very stable clot. And so that infant probably had a hemorrhage probably at the time of, and it was only kind of several days after the fact that they got big enough to be symptomatic.
My worry is, I love ultrasound, but if it's a small bleed, extraaxial, maybe we should do a follow-up a few days later, just because we may have missed it.
It's not generally recommended out there. There's also a question of prophylaxis. Say you don't get the history that there's a, potential for hemophilia until after the fact. You've already delivered this child, vaginally, but you use forceps to get him out because, whatever. And, whether or not you should just a priori prophylax that child. And I would think that the majority of us as hematologists would recommend prophylaxis. And again, hemophilia A being so much more common than hemophilia B, you'd probably put your money on giving a recombinant factor VIII product. Or you could just give FFP after the fact. But hopefully if you've gotten the cord blood, you'll know that history, or you've gotten the venipuncture and you'll know exactly which one to target. And, if it's a very high risk, then yeah, probably a repeat ultrasound would be good. But without that, with uncomplicated labor, I think usually a single ultrasound is sufficient for us in kind of our guidance.
That's really great. So we have a wonderful area of expertise in our center.
Thank you. Thanks for having me.
Any other questions?
I have one question. Regarding the fetal presentation of NATE, have you ever seen other lesion different from intracranial bleeding?
Like skin
or
abdomen?
They can be asymptomatic or with intracranial bleeding.
Yeah.
Why don't they bleed everywhere else?
Why don't they have big adrenal hemorrhages? Why don't they have other, the brain is the most common one.
And why do you think that the brain is the most common side? I have never found an explanation for that.
Yeah, I mean, you also think about, the thrombocytopenia is happening so early, and you think about kind of NICU infants and kind of the very friable germinal matrix. But again, these aren't just, intraventricular hemorrhages. These are hemorrhages kind of throughout the brain parenchyma. I don't know why it's so much more susceptible. With hemophilia, they can present with bleeding elsewhere, bleeding in their mouths, bleeding at circumcision, not prenatally in the postnatal period typically. Typically, hemophilia infants don't bleed prenatally. I don't know why with NATE. I mean, they do have such a degree of thrombocytopenia, but why the brain would be kind of more susceptible than your adrenals, I don't quite know.
And how do you do the in utero platelet transfusion? Is that?
It's a PUB, a percutaneous umbilical vein.
Okay.
Yeah, catheter insertion, and so kind of as they're going in and drawing off the CBC, you give your little injection of platelets kind of all in one fell swoop before you even know that platelet count, typically. Because again, if this is a high-risk fetus and you're doing this because you're worried about NATE, you have your platelets kind of right at hand. They might bleed just from the puncture itself.
Well, thank you so much. Fabulous. Really, really
you.
great. We appreciate it.
Great. Wonderful.